Good afternoon, everyone. I'd like to welcome you all and to begin by acknowledging the traditional custodians of the lands on which we are here in person today, the Wurundjeri Woiwurrung people of the Kulin Nation, and to acknowledge traditional owners of the lands that you may be on today and to pay respects to elders, both past, present, and also to extend that respect to any Indigenous people who might be with us today, either here in the room or online. And I think to take the opportunity to say that 2023 is going to be a very important year for Australia, and I encourage you all to understand the voice to Parliament and to get behind our Indigenous families to make that recognition part of Australia's heritage. I'm Professor Sanchia Aranda. I'm a past president of UICC, so it's a delight to be here today, but I'm here in my capacity as Deputy Chair of the Victorian Comprehensive Cancer Centre Alliance, and I bring apologies from Professor Linda Christensen, who is unable to be with us today. This is our first VCCC Monday Lunch Live for 2023, and it is being kicked off with an important topic of equitable cancer care, which I'm sure is dear to you all. February the 4th, or Saturday last week, was World Cancer Day. World Cancer Day is a global initiative led by UICC that seeks to unite the world around a common purpose and to raise worldwide attention and awareness about cancer, about the need for education and catalysing personal, collective and governmental action. We're trying to reimagine a world where millions of preventable cancer deaths are saved and access to life-saving treatment and care is equitable for all, no matter where you live or what your circumstances are. The 2023 World Cancer Day theme is it's the second year it's been Closing the Care Divide, which is a theme that is strongly aligned to the VCCC Alliance's program and principles and our overarching strategy and the work being undertaken. Today's event was helpfully guided by our Cancer Consumer Advisory Committee, which is really another example of how this important consumer advisory group is inputting into the work of the VCCC. So what does equity mean and why does it matter for patients, for clinicians, for cancer researchers and for the community? UICC has identified 8 barriers that stand in the way of equitable cancer care. These include gender norms and discrimination, barriers for minority populations, poverty and socioeconomic status, the rural-urban divide, age, refugee status and forced displacement, homophobia, transphobia and other forms of discrimination, and barriers of care for people with disability. And I think it's important that we recognise that many of these factors are cumulative and lead to cumulative disadvantage, not to be seen in isolation, but to understand the intersectorial nature of these. Today, we have a panel that will be joining us, Rapatini, Joe Cockwell, Anita Lau, and Gavin Wright and Jennifer Phillips, and I will introduce them a little bit later. My computer, I've been very naughty and not been advancing the slides, but there's weird things that have happened on the screen here. But first, some housekeeping. The event is being recorded and will be available on the VCCC Alliance Open Learning page if you would like to access it. And there's a code there for you. So the program will include initially a keynote speaker on systemic racism and how it impacts cancer care, and I'll introduce Kalinda to you in a moment. Then we'll have some opportunity for a panel discussion and reflections, and then before we close. So it's my absolute delight to introduce Associate Professor Kalinda Griffiths. She, as our keynote speaker, to talk to us about systemic racism and how it impacts cancer care. Kalinda is a proud Yawuru woman and is the VCCC Alliance Research and Education Lead, Aboriginal and Torres Strait Islander Health. And she was importantly recently appointed as the Director of the POSH Centre for South Australia and Northern Territory, which is run with Flinders University Aboriginal and Torres Strait Islander Health Research Centre. Kalinda has many appointments that I won't go into, but I think importantly, Kalinda is very well regarded for her innovative research on Indigenous data governance and data sovereignty and the measurement of health disparities. And so that really makes her ideally suited to our presentation today. So straight over to you, Kalinda.
Thanks, Sanchia.
No, I don't need to do anything. Can people hear okay? Yes, I just need to give you control of the slides, I think Pete.
Oh, I don't have any slides to hand over. So it's just going to be my face at your... But before I begin, I would like to acknowledge the traditional custodians of the many lands on which everyone's dialing in from today, and also where you guys are. So I'm calling in from the unceded lands of the Larrakia people in Darwin. I'd like to pay my respects to all elders, those of the past, the present and the future. And I'd like to pass on that acknowledgement to any other Aboriginal and Torres Strait Islander people online or in the room today. So Naya Nilawa Kalinda Griffiths, Nilawa Corpus, Naya Jandal, Jandal Gora Bibi. My name is Kalinda Griffiths, my family name is Corpus, and I am a proud Yawuru woman. My country is in Broome in Western Australia. And I do work across a range of programs and projects, and my interest is in the usability of existing data and big linkage data for the purposes of research and community development. Also for building capabilities in those spaces as well. I'm particularly interested in the quality of the data being used, where we are measuring, or what we're measuring, I should say, and how we're measuring it as well. I would like to say thank you for inviting me to talk to you about closing the cancer care gap for Aboriginal and Torres Strait Islander people. And I think while there are a great deal of things to talk about when it comes to closing the cancer care gap, today I wanted to speak to you a little bit about data that's used to describe cancer disparities. And I also want to touch on the broader importance that cancer has in regards to national policy, particularly the Australian government's aspirations to close the life expectancy gap within a generation. Of course, overarching all of this are those systems issues that play into some of the reasons why these inequities exist, including systemic racism. But I do want to note before I begin that I use the term disparity purposefully. I use it because it highlights an implicit assumption that the differences we see between populations can be due to social injustices, so an inequity, and not simply a variation in equivalence between two groups, so an inequality. And this is an important term because it describes those embedded systemic issues that we're speaking about, as well as those things that we cannot accurately account for, things like colonisation. So cancer is currently the leading cause of death for Aboriginal and Torres Strait Islander people in Australia, and we've watched its impact increase over the past 10 years or so. And while we've seen improvements over time in regards to reductions in incidence rates, we can see that Aboriginal and Torres Strait Islander people experience liver, cervical and lung cancer at a rate that's about twice as high when compared to non-Indigenous people in Australia. So Aboriginal people are diagnosed younger, at more advanced stages, have higher incidence of primarily preventable cancers, with higher rates of comorbid conditions. Also, we have significantly higher mortality rates and less than optimal care than for non-Indigenous people across the country. Our 5-year survival rates are also lower, which speaks to issues in accessing services that can support earlier diagnosis, as well as the quality of care and that continuity of care after a cancer diagnosis as well. I don't think that there is a way to sugarcoat this at all. The fact is that these are quite damning statistics, and they provide for a clear description of inequality in Australian society. However, there have been major advances in cancer treatment and services more generally, as well as for Aboriginal and Torres Strait Islander people. From 2010 to 2019, we did see a 10% decline in death rates for non-Indigenous Australians diagnosed with cancer. For Aboriginal and Torres Strait Islander people during this period, however, this gap actually increased by 12%. And like I said, despite this, there have been improvements across health systems. There have been improvements in life expectancy for Aboriginal and Torres Strait Islander people, highlighting that the national Closing the Gap target to close the life expectancy gap in a generation is actually attainable. In the Northern Territory, we've seen an increase of 9 years and almost 5 years for men and women respectively. And we're using the Northern Territory data there to show this because it's some of the highest quality data of any of the jurisdictions in Australia. So if we go back to the fact that cancer is the leading cause of death for Aboriginal and Torres Strait Islander peoples, we really must recognise the important role that healthcare systems and cancer services provide in the efforts to close the cancer care gap. So we know inequity is increasing globally, and for particular populations in Australia, the gap continues to get wider. It ultimately does. We already know that Australians living in rural and remote areas, Aboriginal and Torres Strait Islander people, differently abled people, and culturally and linguistically diverse people do not live as long. They have greater levels of disease and injury, poorer access to and limited access to health services when compared to people living in cities and metro areas, to non-Indigenous people, to abled people, and to the general population respectively. We know that this isn't new news. We've known about these inequities for a very, very long time. What should be of concern, though, within the cancer sector is that those services that are there to provide early diagnosis, treatment, and to provide ongoing support for survivors and carers have been developed within these Western constructs and existing systems that typically are based on these dominant model of service and care. Despite our awareness of this, there are really serious challenges with those intersecting disparities as well. So Aboriginal and Torres Strait Islander people living in outer regional and remote areas experience some of the worst health outcomes of any population across the globe. We're aware of the gap. We know as well that the magnitude of its impact is underestimated. And so there continues to be these issues and these considerations with the quality, the accuracy, and the approaches of the data used to describe population progress as well. So data is one of our most critical and powerful tools to advocate for and make positive changes for in society. But to get it right for populations, there is a requirement for people to realise and respect its historical and contemporary contexts, and also to have enough analytical knowledge and expertise about methodologies and statistics to explain what the data is saying within those contexts. There are 3 things to consider when we speak about Aboriginal and Torres Strait Islander data, which is also relevant to other populations. The first thing is who is counted, which for Aboriginal and Torres Strait Islander peoples includes considerations regarding the definitions of indigeneity and the operationalisation of those definitions, as well as the propensity to identify within the data, so the willingness for people to identify in those healthcare services. Secondly, it involves identifying how many people are counted, and this includes the issues of the completeness of the coverage and the accuracy of population counts, as well as those methods that are used by national statistics agencies to address issues of over and under counts. And this is particularly important for getting the numerator and denominator right when we talk about cancer rates. And thirdly, we need to think about what is counted and measured. And this involves developing indicators and measures that encompass Aboriginal and Torres Strait Islander people's states of events, values, and understandings. And that's an area that I think is quite lacking within the Western constructs and the systems in which we function within. So there are a range of limitations when it comes to quality and ultimately the accuracy of Aboriginal and Torres Strait Islander data to be used for the purposes of cancer reporting. Look, we did the first ever semi-national estimates of Aboriginal and Torres Strait Islander cancer survival back in 2010, and we published in 2014. But in over 12 years, we've still not seen any major improvements in the data for Aboriginal and Torres Strait Islander cancer estimates that are reported. We can still only get semi-national cancer incidence and mortality. And there are major challenges with identifying Aboriginal and Torres Strait Islander people within the national screening programs as well. When it comes to service provision, we also need those appropriate measures that reflect the experiences and needs of Aboriginal and Torres Strait Islander people with cancer. So some of the work of Professor Gail Garvey and Professor Joan Cunningham and Dr. Monica Green are giving some promising developments in this area. However, we do require better population data in order to appropriately assess those cancer services and where people need those services as well. Basically to ensure that health services work for the populations that they actually serve. If we are to bridge the care gap, then we need to identify what people's needs are in health and cancer services in order to provide culturally competent and culturally safe healthcare systems that can address these complex intersecting issues. We need to recognise the tensions that also exist with Australia, the nation generally and Aboriginal and Torres Strait Islander people, but the data that's collected within that space as well. So the conversation about the context of Indigenous data is often a challenging one to have. It's certainly politicised, but it is required to go through if we want to grow and move forward in data developments that can support health equity. So official data collected by governments on Indigenous peoples is developed in what we call a colonial racialised context. And this is what has resulted in coloniser sanctioned forms of recognition. What do I mean by this? Well, the recognition of identity, who we are, can be achieved by Indigenous peoples for Indigenous peoples, but we need to really be cognizant that the recognition of indigeneity within data has only historically ever been granted by governments. So as an example, the Australian government officially counted Aboriginal and Torres Strait Islander people from 1901 to 1967 for the sole purpose of excluding us from the national population count. And in 1967, Australia had a referendum which resulted in changes to sections 51 and 127 of the Constitution. And it was the change to 127 that resulted in the inclusion of Aboriginal and Torres Strait Islander people in the census. This inclusion only arose from the nation's moral imperative to include and count Aboriginal and Torres Strait Islander people as national citizens via that democratic vote. So our starting position with the data and with Australian society is within this paternalistic power differential. Since then, data has often been used as a tool to continue negative stereotyping and as a way to politicise Indigenous issues. And this has continued, I guess, it's continued to contribute to that lack of trust in governments and also the healthcare system, where data could be a tool for good. It's often questioned as a potential weapon. So in order to work to improve Aboriginal data, which includes Aboriginal cancer data, there needs to be a deeper understanding of the need for Indigenous data sovereignty and governance that recognises and respects the context of Aboriginal and Torres Strait Islander people in society today. So Indigenous data sovereignty for the audience has been defined by Tahuku Tai and John Taylor as the inherent and inalienable rights and interests of Indigenous peoples relating to the collection, the ownership and application of data and information about their people, their lifeways and their territories. So Indigenous data sovereignty is a way to assert self-determination in the way in which we control, maintain, protect and use data. And so when it comes to population level cancer data, it goes back to our discussion about recognition and measuring those things that matter to Aboriginal and Torres Strait Islander peoples, prioritising that. The information required to assess where we're at and how we can better close the cancer gap between Aboriginal and Torres Strait Islander people and non-Indigenous people requires this accurate, relevant and appropriate data. Yet there continues to be limited visibility of Aboriginal and Torres Strait Islander people in the cancer data. We need this data as well as data for national cancer control indicators to ensure that we're able to better report on Aboriginal and Torres Strait Islander outcomes and needs as well. The issues and the quality and accuracy of Aboriginal and Torres Strait Islander people in national health data should actually be of a major concern to health service providers and policymakers. This information is required to support the health of the population, and without it, there is limited visibility of Aboriginal and Torres Strait Islander inequities generally. So this year's World Cancer Day and its theme, Close the Care Gap, happens to come at this really pivotal moment in our nation's history. And we've got this momentum at the moment building towards a voice to Parliament. So Makarrata, which means treaty or agreement making, has the potential to have profound and positive impacts on the health and well-being of Aboriginal and Torres Strait Islander peoples and our communities. And at both the federal and state levels, the dialogue, the yarning, the truth-telling arising from this process acknowledges the history and the trauma of dispossession and its impact of generations on Aboriginal and Torres Strait Islander people and our country. So much of this discussion is embedded in the need for constitutional recognition for Aboriginal and Torres Strait Islander peoples, for that recognition of our unique and enduring cultures, and to better support leadership in our own affairs as well. And so when we look at these aspirations within the cancer care sector, there are a complex array of barriers to this recognition and this leadership. Systemic racism, limitations in appropriate, culturally safe healthcare sectors continue to negatively impact Aboriginal and Torres Strait Islander people's experiences in cancer care and outcomes. We're required to move from the mindset of equality to equity, recognise that we all have different needs. This requires much work and both personal reflexive work to better understand where we fit in the story and how we can do better. There's also much work to do to build the evidence base in how to best improve the healthcare and cancer systems. And for those responsible, I guess, to build these liberated, safe environments for all people, not just that dominant culture. But it isn't all bad news. Relatively, we've seen so much movement in cancer equity in Australia. And in the past 20 years, particularly the past 10, this movement's been quite quick. Since the first review into Aboriginal and Torres Strait Islander cancer back in 2003, there has been a number of people that have worked through international and national partnerships to bring these learnings and to build the research capacity in the nation that can better support those cancer services and systems. So the Cancer Council Australia convened the first ever roundtable on Aboriginal and Torres Strait Islander cancer in 2004. And this was followed by the first national roundtable on priorities for Aboriginal and Torres Strait Islander cancer research. It was a conference back in 2010. And this was a partnership between the Lowitja Institute, so Australia's Aboriginal and Torres Strait Islander Researchers Institute, and the Queensland Institute of Medical Research, QRMR. It brought together leading experts, Aboriginal and Torres Strait Islander cancer survivors and community members, as well as representatives from Aboriginal and Torres Strait Islander community-controlled organisations to develop national research priorities for better outcomes for Aboriginal and Torres Strait Islander people, their families and their communities. At the national policy level, there's been quite a bit of movement too, and the National Aboriginal and Torres Strait Islander Cancer Framework was developed in 2015. And this was to provide high-level guidance and directions to individuals, communities, stakeholders and governments. Additionally, the Optimal Care Pathway for Aboriginal and Torres Strait Islander people with cancer was published in 2018. Many of you have come across this. It also provides guidance, but is specific to health practitioners and service planners for the optimal care for Aboriginal and Torres Strait Islander people with cancer. There's a lot of implementation work going on at the moment with that. The ongoing development of the Australian Cancer Plan by Cancer Australia is also informed by the leadership group on Aboriginal and Torres Strait Islander cancer control, and that group's been around for a little while now as well. So I think identifying how these high-level documents, particularly the optimal care pathways, can be effectively implemented and can work on the ground are critically important for some of the next steps. At the moment, the National Aboriginal Community Controlled Organisation, or NACCHO, are developing the National Aboriginal and Torres Strait Islander Cancer Plan that can overarch all of this work as well. And there's also much work being undertaken across the jurisdictions. And with the Victorian Aboriginal Community Controlled Health Organisation, VACCHO, they're rolling out their Aboriginal cancer journey strategy as well. at the Victorian Cancer Centre Alliance, we have an entire pillar with our strategic framework dedicated to cancer equity, with Aboriginal and Torres Strait Islander people being one of our priority populations. And so these efforts make a difference in the capacity for systems and services to be aware of the needs of Aboriginal and Torres Strait Islander peoples. There is, however, a serious need to increase efforts in ensuring that we have the staff and resources required. If we're going to change the trend and close the cancer care gap, there needs to be investment in embedding equity as a core funded element in healthcare systems and services. We need to work to better understand and eliminate the barriers and the challenges, including those things that are systemic and ingrained and sometimes a little bit embedded in the walls in which we work and live. And recognising that these are very real challenges that Aboriginal and Torres Strait Islander people face. We can do this through supporting Aboriginal and Torres Strait Islander voices and leadership in research, education and health. And I'll leave it there for today, but I wanted to say a very big thank you for having me.
Okay, thanks, Kalinda, very much. And while I'll get our panel to come up and join us, but while they're going, just to really, I guess, reflect a little bit on that presentation. And you know, you've highlighted the criticality of data in the sense that if you can't measure something, you can't actually address and control it. But it's also fair to say that Australia is falling significantly behind in a global sense on data, and I'm interested in your reflections on that and whether things like access to the MADAP data set are starting to shift that and give you more access to the sorts of nuanced data that you might need to understand outcomes for Aboriginal and Torres Strait Islander people.
So the national population data assets are really important for this work, and we are able to do enhancement approaches with the use of that data. I think it's such an exciting time in regards to data sharing in Australia across the governments. But there needs to be recognition that there is limited trust from Aboriginal and Torres Strait Islander peoples and communities in government processes. And that requires that governance structures are set up appropriately and correctly, so we can do incredible things with the data, but if the governance isn't there to ensure that Aboriginal and Torres Strait Islander people can lead the discussion on what happens with that data and the data that pertains to their, I guess, their jurisdictions and their communities, then there are going to be some challenges with how we move forward with that. And so I think, you know, the next step is going to be having those discussions. And, you know, we have infiltrated to be able to have those chats with higher level government committees as well. But yeah, I'm excited about the use of those data. And we have been utilising them. We used them across COVID-19 particularly as well for enhancement purposes. So we're able to access Medicare data to enhance some of the vaccine data as well. And, you know, as we move forward, we're going to find more improved methods and approaches to be able to get that population estimate up. Yeah.
Terrific, thanks. So we understand that some of you are having a small screen picture, those of you online. So if you go to the top right of your screen and swap shared screen with video over, that should help fix the problem, and hopefully you'll get a bigger view of the panel. So it's my pleasure now to introduce our panel, and I'll start from my far right. Professor Jennifer Phillip is the Chair of Palliative Medicine at the University of Melbourne and is a palliative medicine physician at St Vincent's Hospital, Peter MacCallum Cancer Centre and the Royal Melbourne Hospital, and the lead of the Palliative Nexus group. Next to Jennifer is Joe Cockwell, and Joe is an original member of the VCCC Alliance Cancer Consumer Advisory Committee and currently the Deputy Chair. She's served the Peter Max Consumer Advisory Committee for 7 years and the Walter and Eliza Hall Institute Consumer Advisory Panel for 4 years, and is currently a member of the WeHi Consumer Research Program. And Jo's a passionate advocate for cancer research and equitable cancer care. Next to Jo is Dr. Anita Lal, and Anita is a Senior Research Fellow at Deakin Health Economics, and her PhD examined ways of operationalising equity into cost effectiveness analysis, which is incredibly important. Next to Anita is Associate Professor Gavin Wright, who is the V.C.C Alliance Research and Education Lead for lung cancer and Director of Surgical Oncology at St Vincent's Hospital, Melbourne, and a consultant thoracic surgeon here at Peter Mac and at the Royal Melbourne, and is really a key advisor into Cancer Australia's Lung Cancer Advisory Committee, and of course lung screening will be a big part of that. And finally on my right, Abe Rapatini, who is a Māori man of Ngātai Kahunuhu and Maniapoto iwi, with ancestral links to Palawa country in Tasmania, which is an interesting story that he can talk about. He's got a background in medical anthropology and international development and has managed projects across health, disability, aged care, digital transformation, and Aboriginal social and emotional wellbeing, and is currently the Director of Population Health at the Victorian Aboriginal Community Controlled Health Organisation. So fantastic to have you all here. Kalinda, I'm going to go to you first and ask you to think about, to talk to us a little bit about what are the critical success factors if we're going to change the status quo. How optimistic are you about achieving these, and how do you think we make the system accountable for their achievement?
One thing that we haven't really spoken about being in service to community, and what that requires again is setting up structures that enables Aboriginal and Torres Strait Islander peoples, but also, you know, any other underserved populations' voices. This has worked really well with the Cancer Consumer Group, and we now have the Equity Advisory Group and the V.C.C Alliance. And so what ends up happening is that you end up you start changing systems from within in terms of process. And, you know, it takes a long time for system change to occur. Ask anyone who's worked in health services and health services research, and they can attest this. You know, you're looking at 10-year turnaround times. But ultimately, it's about having those voices front and centre and ensuring that they are the right voices. It's a really challenging approach when it comes to driving equity. I think it's not an easy path to take, but once you get the system set up to be able to do it well, it becomes part of your normal everyday process. And so you've got to start with that internal, I guess, structural shift. And, you know, that can be quite hard to take on the initial decision makers on that front. So that's, I'll leave it there.
Thanks, Kalinda. Gavin, Kalinda's talk has really highlighted poor quality data and as both a cause and an effect of systemic racism. We're about to implement, hopefully, lung cancer screening in Australia. What are the sorts of parallels that might impact on the screening program that you see coming out of her talk?
Yeah, thank you, Sanchia. Look, I think there are two issues where I think this will be important. One is, if there is a screening program, it must work in the Indigenous population, because that, as Kalinda's mentioned, double the incidence, double the mortality. You know, it's a scourge. You know, I've met Indigenous patients who've had multiple relatives die of lung cancer, and some within days or weeks of diagnosis. You know, which is incredulous, really. So it must work, but to make it work, we have to be sure we have co-design with not just sort of nationally Indigenous sort of groups, but obviously each geographic area may have considerable differences that need to be addressed. So co-design is going to be important. We have to sort of tread the line between not being paternalistic, but in allowing local groups to have agency, but informed agency. So we have to actually help with giving information that's necessary for them to actually use their agency. So that's the first thing. Second thing is in the screening program itself. Unfortunately, we didn't quite get in the MBS wording quite what we'd want. It really doesn't allow for inequities and disparities. It really just says, right, this much smoking, this age, as if everyone is identical. Doesn't allow for different levels of education, disadvantage, other family histories of cancer, lung cancer in the family, any of that's all. I mean, on one hand, it's nice and simple, but on the other hand, it's one of these systemic things that that Kalinda's highlighted.
And one of the things about the equity parts of that is if you take the bowel screening program, for example, where disadvantaged groups are less likely to receive follow-up after a positive test, how are we going to avoid that? Is there anything else that needs to happen in terms of the system to make sure people who have a positive screen stay with it?
I think that just highlights that it has to be, by the people, for the people. It has to be a co-designed thing that the Indigenous groups themselves would like, and they know how to work. They don't need a government or someone like myself say, you must do this.
Abe, drawing on your experiences in both New Zealand and Australia, we've already had a little bit of a conversation about the significant differences in a country that has a treaty where the voice of Indigenous people is well and truly represented. What do you think are some of the challenges that you've seen in Australia that are different to the ones in New Zealand? And can you highlight maybe some successful interventions or processes that you've seen take place here?
I think the challenges are broadly the same challenges, and you can see the same problems across places that have been colonised internationally. Closing the gap in cancer care and closing the gap more generally is something that the health system can't do on its own. It needs to be done by everybody. So it needs a whole of government approach, it needs a whole of community approach, because as Kalinda was saying, Aboriginal people have very good reasons not to trust health services and not to trust social services. These are services that are meant to be there for the benefit of people, and historically they've inflicted incredible harm. So to reverse that harm and to successfully close the gap, we need to see a restoration of all of the things that were stolen from Indigenous communities. And that's culture, language, country, kinship, connection to ancestors, knowing where you come from, having a place, being secure and safe in your identity. These are things that most people in this country take for granted. Most people in this country are born benefiting from several generations of the accumulation of wealth. Aboriginal people, in many cases, are born with several generations of accumulated trauma. And that's the impact, the long-lasting legacy of colonisation in this country. And in Victoria in particular, it was very violent, it was very fast, and it was very brutal. And so to reverse that harm, as Gavin was saying, we need to put community in control of the process, and the health system needs to come in behind to support the process of restoring all of the things that were stolen. In terms of interventions that work, we need to move away from, within the health system, having diversity as the outcome. We need to move past that. Diversity is good. but it is the bare minimum that we can expect. So having diverse workforce, having diverse spaces is excellent, and we should strive for that, but it doesn't end there. That's just the very beginning. We need to start having a health system that is thinking about their approach in this space as one of capability. We need health services to be developing the capability to produce equitable outcomes. And that means having critical consciousness of why there is a gap. We can't close the gap unless we understand why it exists. And that means having health professionals that are trained to understand the life experiences of Aboriginal people and the social determinants of health and all of the things that are going on in an individual's life, which has brought them to the point of a cancer diagnosis and then being in front of you within a consulting room. So to close the gap, we have to understand why it's there. We have to be led by community, and in health services, that means also being led by our Aboriginal health units, and the Aboriginal hospital liaison officers and all of the hospitals across Victoria do an incredible job at this. And we need to be thinking about how we train health professionals to be critically conscious, not just of the medical reason why someone is sitting in front of them, but of their life journey that started not just at the point of diagnosis and not just even at the point that they were born, but actually started several hundred years ago. And so for us, this is not just a matter of improving care, it's a process of reconciliation, and it's a process of healing individuals, communities, and then this country as a whole.
Thanks, Abe. Joe, the issue of racism is not only a factor that causes inequality in cancer outcomes, but what are some of the domains of disadvantage that you see in your work with consumers that impact cancer outcomes? And in particular, then, how do we make sure that our consumer voices are diverse so that we can bring those voices into the conversation about inequity?
Thanks, Sanchia. I think I've got some wonderful advocates here for consumer participation at high levels, listening to our wonderful speakers so far. I'm going to just reduce this, not reduce it, but to actually just put it very simply, that who we are and where we come from and where we live and even who we love really cover the domains of disadvantage. And it's a really simple way of looking at it, but it also highlights the absurdity of inequity, because those things are just aspects of people's lives. And the domains have been mentioned, I think, with our previous speakers, and Sanchia, you mentioned them in the introduction, that, you know, socioeconomic status, refugee status, access to language in English, health literacy, just to mention a few of them, geographical remoteness. There's so much that influences the impact of cancer on people. And I guess it's really important to note, and it's already been noted here, the intersectionality of it too, that we are looking at consumers who are patients who are have several domains of disadvantage overlapping, and we need to acknowledge that and really understand it. And the way to do that is to really bring in consumers with diverse backgrounds, because I think we've had mention already too about geographical remoteness. We know that geographical remoteness really can limit access to clinical trials, for instance. It can limit to treatment options. And who do we need to actually work with that is the local people in that geographical area. Gavin mentioned co-design. It's just so important that we have a diversity in the groups that are advising on co-design. We have diversity in community consultation process. And I always find it amazing that we just go back to basics. How can we possibly understand the inequity within health services if we don't actually ask the users of those services? And they are a diverse group. The VCCC Alliance at the moment has a value-based healthcare program, which is absolutely fantastic, that we are looking at what consumers value. But how do we know that if we don't actually ask them? And consumers are not one group. They are a diverse group. So it really is a no-brainer in a way that we even think about this. Diversity is absolutely essential in the whole of the voice that we're using.
So what do you think, what have been the successful mechanisms that you've identified for actually drawing on a wider and more diverse range of consumers? Because it is really difficult. And when you're talking about people with disadvantage, they've also often got less leisure time, less resources. How do you think we can do better in that area?
Well, I think the first thing we need to do is actually ask underserved groups and people in that position to how to best communicate with them. What is the best way? And, you know, what should we do to actually engage? How do we do it? That's the first thing. I think we have to really be determined about going out and constructing groups that are diverse, actually recruiting people, asking people to be part of it, and giving them motive and understanding about the benefits for them and for consumers generally, patients generally, to have the diversity within the group. But it has to be a concerted effort. It's something that people have to go out and actually do and work with people to find out the best ways of doing it.
And Kalinda's already sort of mentioned the whole issues of trust and how we make that safe for people to talk about their stories.
Yes.
Terrific. Jen, we've got a question for you around a very often forgotten population of people with cancer, and that's those who are incarcerated in our prisons. Can you tell us about your research a little bit and what key challenges and issues you've identified, and then maybe talk about the strategies that you're working on to improve access?
Yeah, thanks, Sanchia. I think this is a particular group, but obviously a group that experiences many disadvantages, you know, all at the one time. And I think it's worthwhile just putting it in context that people who are incarcerated can expect to live about 10 to 20 years less or shorter than the general population. And that is as due to a combination of multi-morbidity and being in prison and the social complexity that surrounds all their lives and that situation. And I think the other sort of bit of context which is interesting is that the system of justice and the imperatives of that around constraint and limitation and indeed, you know, punishment are so often at odds and intention against the systems of health, which is seeking to promote well-being and good outcomes. So I think that plays out in lots of different and sort of interesting ways, in very tangible ways. For example, in Victoria, access to tertiary healthcare is through Port Phillip Prison, which is a high security prison. And if you need to access, for example, an outpatient oncology appointment as a person who's incarcerated, you have to do so through Port Phillip. So that might mean that you are in a low security facility and enjoying, or, you know, having the less of the limitations on your lifestyle as you are in that. But if you then need to access healthcare, then you have to be transferred to the high security system to access it. And if it's ongoing treatment, then you stay there whilst you're having treatment. And so people make decisions about actually whether they will access treatment based on where they want to live. And I don't, you know, that's something that we don't have to do by any means. As a palliative care physician, often our treatment decisions are intensely constrained by being in prison. So, for example, a person can't readily access as required extra pain relief if they're in prison. They can't use patches for pain relief if they're in prison. So there's lots of treatment decisions that are also constrained by this. So there's been, you know, a number of things that have been done and thinking through to try to address some of these constraints within the limitations of that initial tension that I outlined. And some of those, there's some interesting in-reach models from the UK that are being also applied here in Victoria, around where community or hospital services are actually going into the prison to provide support and education and training for staff, secondary consultations, and indeed telehealth consultations for prisoners. And telehealth has enabled lots of sort of interesting opportunities, I think, and, you know, a good thing out of COVID. I think another interesting thing and possible improvement in how we do things is development, but real clarity around some of the policies, around some of the aspects of care. So, for example, application for compassionate release is a process that takes a long time, and thinking about that early and knowing what the steps are to think that through and who's responsible for what. Removal of shackles for people who are in care. All these things are decisions that as a clinician need to be sort of navigated through the system of justice. But there is work in all of these spaces, and I think things can be improved, albeit it's small steps.
Thanks, Jen. Anita, a lot of the strategies and conversations today will require more resources. While equitable cancer care has to become financially viable, we need a financially viable approach. But what are the sorts of things that we need to do from a health data and the sorts of research that we need to do to build the case for investment in reducing disparities?
Thanks, Sanchia. So, hi everyone. So, what I wanted to say today was talk about the in health economics. I'm a health economist, and we evaluate programs for their cost effectiveness, and we make recommendations on funding of programs. And there's always tough decisions about what needs to be financed. And I specialise in equity, so I analyse programs for their equity as well as their cost effectiveness. And these programs can be ranked. So the program that increases equity the most and is the most cost effective would be the one that's recommended for funding first. So just to give you an example, if we look at the bowel screening program as it is now, and everyone receives a letter in English, a standard letter with their bowel screening kit. If we wanted to increase screening in culturally and linguistically diverse groups, we could offer a letter in language with brochures in language that go with the bowel screening kit when they're sent out. We could offer education programs in language, mass media programs in language, and these could all be compared and analysed to see which one has improved equity the most and which is the most cost effective, and that would be the first that's recommended for funding.
And is there a lot of emphasis, I guess, momentum behind building equity into health economic analysis? Because it really has been very focused on cost effectiveness alone, which is likely to actually widen equity gaps rather than close them.
Yeah, it's a developing area and one that I'm really passionate about. I think it's about educating decision makers as well, and also having the right data, which a lot of people have touched on today, about having accurate and sufficient data to analyse the programs. And that leads me to this point that Kalinda brought up about bowel screening data, about Aboriginal data not being identified, and it's also that issue with culturally and linguistically diverse groups in the language spoken at home. And so I've been analysing a program that's trying to improve screening in culturally and linguistically diverse groups, in Arabic and Mandarin groups, and the Cancer Council been running great programs that have covered mass media and community education programs, but it's really hard to analyse how effective they've been because the language spoken at home hasn't been recorded when the kits are being returned. So only about 20% have the records of that. And so ideally, the Medicare records would be linked to the kits that are being completed.
And of course, the lack of follow-up after a positive test. It's only 53% of people with disability. So, we really do have some major issues with equity in our programs. Terrific. So we are getting close to our end, and we've got a number of people. So I'm going to ask you each and I'll leave Kalinda till last, but if you had to nominate the one thing that would make cancer treatment more equitable, and the experience more equitable and the care outcomes in the last 5 years, what would it be? What would be something that we could replicate to build more equitable cancer care? Not. You can yell out if you want to. Go first, Jo. Off you go.
I think for me, I think it's already been mentioned. Equity is everybody's business, and the benefits are for everybody. And I think for me, it would be the increase in consumer participation across the board, and particularly at high levels, at the co-design level or partnership and leadership levels, which I think can make a difference into the future if that trend continues.
Looks like you're in the hot seat, Jen.
Yeah, I think so. So this is not a big picture thing, but just a medium picture thing. I think that telehealth has been quite dramatic in improving equity, particularly for people who would otherwise struggle to travel or to access appointments and such. I do think that we need to embrace this carefully, though, because there is a chance that it could also exacerbate inequity in terms of, access to data, etc. So telehealth in a qualified way.
So this is a really specific example that I've been working on myself. It's an evaluation for Breast Screen Victoria that, so during the COVID pandemic, culturally and linguistically diverse women were less likely to come back to get screened. And Breast Screen Victoria ran programs they've been sending SMS messages in language and doing outbound phone calls and running group screening appointments with an interpreter. And these have shown to be really effective. So 5 years ago, they would have just received an SMS in English, and the rates of rescreening have actually doubled now due to these in-language SMSs.
And in fact, SMSs are one of the few, reminders are one of the few interventions that's got really good evidence behind it. Evan.
Oh, this might be a cop-out, but I think culture of government is the thing that's going to, as Abe said before, you can't just change health. You've got so many other things need to be changed. So I think it needs to be, we need governments that are both culturally aware of things, but also that do truly represent and do truly get opinions from the population.
Or everybody needs to have a look at Jim Chalmers' essay on value in government. So,
can I have two?
okay.
I have one, which is greater support for people to navigate their cancer journey. The health system is vast. Cancer treatment and care is extraordinarily complex, and some of the jargon is just insane. So it's an overwhelming thing. And on top of everything else that's going on in your life, with your family obligations, needing to take time away from work, needing to manage whatever situation is going on with housing and other things, support there, not just within services, there are very good supports within services that can connect you up, but actually from the start to the end of the cancer journey, and having coordination services there that also connect up to in-community and in-home support as well is critical. And the other is we need to incorporate culture into care and treatment pathways as well. And so another Breast Screen Victoria initiative in partnership with VATCHA was to design and develop shawls that women could wear around themselves when undertaking their breast screen. And that's been an extraordinary reversal of the experience of undertaking a breast screen, because it replaces stigma and shame with empowerment and with celebration, both of womanhood and of undertaking something which is protecting yourself, protecting your family, and protecting your community. And so the ability to flip the narrative from one that has been characterized by deficit and fear and anxiety into one of celebration, survival, and empowerment is extraordinarily important for Indigenous peoples.
And you'll be excited to know that both of those things are in the National Cancer Plan. And to really focus on the fact that navigation is about a system, not about a person doing it. So, Kalinda, over to you.
Yeah, all of these are like, it's a multi-tiered approach, right? And so every single person who has made comment today has noted that it's about people's voices, whether it's at the higher government level, whether it's at that, you know, in-service screening level. You know, for me, it's about ensuring that there is the leadership of those underserved people in-house across all tiers of the process. That includes government, right down to the services that provide for people. The challenge with this, though, is that we don't have enough people to go around. Everyone who works in the sector is often, overworked and not enough time to do what's necessary. And so, that comes to the conversation around ensuring that we have people who are aware of what's going on, are reflective within the systems that work for them. This comes down to cultural competence and cultural safety. And it also comes down to valorization. So ensuring that those values and understandings and beliefs are embedded in the structures that work for the people that it serves. So, yeah.
Perfect, thank you. And as one of those people who's spread very thin, we value your attendance here today, Kalinda. So thank you to all of our panellists, to our virtual audience for tuning in, for those of you who've managed to make it here face to face. Just a reminder that the webinar was recorded and will be available on the VCCC Alliance Open Learning page. And this is the first Monday lunchtime live for 2023. So check the website for forthcoming events and have a fantastic afternoon. Thank you very much.